Three.
Okay, hello everyone, and welcome to today's Journal Club. It's a discussion on do-it-yourself to doctor, how patient-doctor conversations improve outcomes. Next slide, please. Nope, not that one, the one before, but that's okay. I thought there were two. Our discussions today, our discussion leads today include Dr. Phil Molloy, a rheumatologist who continues to be very active in caring for patients, and we appreciate his continued support despite retiring. Dr. Jehan Marcoux, a cannabinoid researcher who continues to wow us with his writings. And Dr. Len Kamen, who we hope will join us as a physiatrist from Jefferson University. Like I said before, he might be delayed in joining as he tries to squeeze us in during his lunch break from seeing patients. And so I'm looking forward to their discussion and perspectives on this paper. We do need to end promptly so that they can go back to their busy schedules. Next slide. All right, for those of you new to our program, I'm the CEO of Physicians Research Center Plus. It has three pillars. Salus is our clinical research pillar, Buds Info is our analytics pillar, and Cerium is our health education program that brings actually this program for you today. Next slide. We look forward and we want to thank you for taking the time to engage with us. If you have a minute, I don't know if you've done this before, but if you can scan the QR code, it's just a questionnaire, a healthcare provider health questionnaire to give us a little bit more perspective on maybe how we can better serve the healthcare provider society and with cannabis as we try to root the program in science. All right, next slide. I think this is where I hand it over to you, Jaihan.
All right, welcome to the Cerium Journal Club. And the mission and vision of the Cerium Journal Club is to support the education of healthcare professionals with discussions of published research. And we do our best to approach each paper with consistency, fairness, and transparency, and try to point out any biases we have when it comes to it. But I think, as Dr. Molloy and I have talked about, our bias is towards more data. Again, the purpose of this journal club is to educate and raise awareness. We're not recommending any policy or regulatory decisions. And if you haven't already, leave your email address in the chat. We can offer invitations to future journal clubs and other events and help you share this with your colleagues. So, Dr. Molloy, as we know from reading this article, there are some issues and questions around healthcare provider awareness and particularly guidance offered. And some of the initial questions around this issue we'll discuss are, do patients initiate the discussions with their doctors? Do the healthcare providers initiate the queries? And how confident are healthcare practitioners in answering these queries and providing advice on it? And does it actually affect the outcome if people who are using cannabis for a particular reason or outcome have a discussion with, say, their primary care physician? You might think, yeah, of course it might have an impact, but where's the data? How do we know? And so, Phil, I thought this was a great article
Yeah.
you found entitled Impact of Healthcare Provider Awareness and Guidance on the Medical Cannabis Experience. And this again was published this year. I think it's a bit of a novel study. It's certainly a great questions they were asking. So
Yeah, I'd like to throw out there that there's a lot of barriers to healthcare providers having these discussions with their patients. I think the first barrier is our own education. A lot of us as healthcare providers, surveys have shown we don't have a high degree of knowledge and confidence in having these discussions. We wish we knew more. Second is our patients don't have a lot of confidence in us as being knowledgeable sources either or credible. They perceive that we might be biased. They don't want things in their medical record. So there's a lot of biases, not to mention politics and where you live in this country and different states and so forth. So there's a lot of barriers to patients bringing it up. We're always behind. We have time pressures as well.
and I think that's a great way to say it. And to sum up that, when patients and HCPs are engaged, the outcomes are generally better. And, I think part of our issue with answering these questions of how to someone to have the best possible outcome if they're going to use cannabis, I think we have some issues with being able to answer that question, such as medical users or people who are using for medical reasons may or may not obtain a medical card. In some states, you know, it essentially adds a fee to being able to buy these products or acquire these products. And so we may not, some people may not obtain those cards. But even in states like Oregon and Washington, where cannabis is available for adult use, you still see a significant portion of people register as a medical cannabis patient. Um, and because of that, many will not inform their primary care physician or proactively disclose this.
I think the point is that if you have a medical card, you might be using it recreationally. And if you use it recreationally or obtain it recreationally, you might be using it for a medical reason.
Absolutely. And Dr. Len Kamen has joined the chat here. Um, Welcome, Len.
Hi, guys.
Thank you so much for joining us. We were just getting started talking about a little bit about the paper, so feel free to jump in whenever you'd like. So we were just going to talk about the hypothesis, or I guess, yes, it's the hypothesis. It's not a theory yet because it doesn't make accurate predictions that we know of. But their hypothesis, what they think might be happening here is that medical cannabis patients who collaborate or disclose their use to an HCP may find that the cannabis products work more effectively, may use less THC, may use more CBD, and maybe they'll experience fewer side effects. I believe this was what the authors of this study, kind of their intent was, their hypothesis.
I think it's a good time to read those four outcomes and to take a guess, those of you who haven't read the paper, what the results are going to be. Do patients or users find cannabis more effective if they engage with their doctors? Do they use less THC? Do they use more CBD? And do they have fewer side effects? What do you think before we look at the data from this survey of 1,000 patients?
Well, we well, there'll be more time to chime in if folks are tuning in and unable to mute now. We could run the poll now, or we could wait a little bit. What do you think, Phil?
It's a simple poll. Let's run it now and not give the results now.
Ooh, I
Give it
like
late,
it. I like it.
give the results after we look at the tables, maybe.
All right, we will launch this poll. So we'll just have two questions in our poll. Please take a moment to respond. And they're simple questions. And we'll revisit these later after we look at the data. When an HCP recommends medical cannabis, it results in lower exposure to THC. So a patient meets with a clinician. Do they tend to use less THC? And the same thing, does HCP talking with medical cannabis tend to result in higher exposure to CBD? And of course, we mean by that, they maybe seek out more CBD, use more CBD, buy more products with CBD. Great. And the results are rolling in. Very, very interesting. Very interesting. I can't wait to, oh, wow. Results are changing. All right. We got all but one person has responded, and I'd hate to mark you absent for your participation. All right. This is great. I'll close the poll in a few seconds and we'll come back to that. But it looks, some people believe it's true that it results in lower exposure to THC. Some people believe it's false. Some people believe, yeah, it will result in exposure to CBD. Some say, nah, it doesn't affect that. All right, we will end the poll. We'll come back to those results and just see what our hypotheses think about their results. All right, so I'll show those results in a little bit. So let's move on to the demographics a little bit, how the study was conducted. So the patients in this were self-identified as using cannabis to, quote, treat or aid with any medical issue, again, regardless of having a medical card or not, or being a registered patient, and again, regardless of whether the product was recommended by their primary care physician. I think they had some generally good inclusion criteria, over 18, residing in the United States, having used or currently using medical cannabis. So and I'm happy to come back to this slide or any of these slides throughout this discussion. So there were some stratified groups, that they looked at, such as whether the medical cannabis was recommended by an HCP and whether the HCP knows about this cannabis use. So they did look at those two categories. They were primarily interested in perceived efficacy. And I think they did a good job here of not only is it the end user, the patient's perceived efficacy, but also the clinician. Did they perceive that the outcomes were better? And also side effects as well. But we'll talk about some of the limitations with reporting of the side effects, which would be
When you
great
look at
use.
the
Yeah, go ahead.
when we look at the tables coming up, I think these first two stratifications, I encourage everyone to just imprint them in your minds right now. Physician recommended or physician aware. All the data is going to be presented to you as to whether or not my doctor recommended cannabis to me or whether my doctor was aware of it. In other words, I told them, or whether they recommended it. So all the data will be presented to you in those two formats. Doctors recommended it, doctors were aware of it.
And they collected a lot of variables, so just buckle up as we go into the figures. Some of the figures have a lot of information. We will highlight some of the key points on those figures as well. And this will be available for your viewing for recording on YouTube as well if you would like to go back. But again, they tracked a lot of different stuff. The tables on route of administration are very interesting. So just to prime the pump, as it were, prepare your brain. There are 7 tables and 2 figures, and the tables include demographics, reported ailments, routes of administration, routes and side effects, frequency of use, including the recommendation and awareness, as well as the results of provider recommendations and provider awareness. So again, kind of two separate little categories there where the provider has recommended the cannabis and whether the provider is even aware of it, how that affects outcomes. And perhaps the two most important figures of which they base the large portion of their conclusions is these figures on perceived efficacy by clinician recommendation and perceived efficacy by knowledge. Very great figures. So diving right in to table 1, always great to see this in a paper, demographics. So high points here. I'll hit the high points, and Dr. Molloy, Dr. Kamen, and Ms. Simon, you're welcome to chime in. But they surveyed 988 US medical cannabis users about age, gender, race, ethnicity, education, and provider involvement. Couple of key data points. 55% had a provider recommendation, and about 67% disclosed their medical cannabis use. Majority were white and female. And the average age was 41 years, with I think the average age of first use being 27 years of age.
I noticed that it was just a point of note is that the higher education you had, the more likely your provider was to recommend it to you. So if I'm less educated, my provider is less likely to recommend it to me. And if I'm more educated, slightly more. Not that it reached impressive statistical significance, but it's just a trend I noticed I thought was worth commenting on.
Oh, I have to say, some of the packaging and instructions on some cannabis products, I think you might need a master's degree to understand some of that information.
The
Jay,
other thing, these are self-selected respondents to a questionnaire. So there might be people less likely to respond. Maybe people whose doctors didn't discuss it with them are less likely to even respond to this questionnaire.
Fair point.
Jahan, was there a differentiation between which states that this was surveyed from? Because there's states with medical marijuana and there's states with recreational marijuana,
Mm,
and there's some states with both. But I think
Well,
that
yeah,
does play a role.
there is, Len, but I don't have gritty detail for you because the reference to this study has not been fully published yet. I mean, the people who did this survey have not fully published it yet, but in their comments, it said they included states where it was legal, illegal, where it was just medical, whatever. They said they included all the states. Yeah.
excellent.
I don't know how many. Yeah,
Well, we're going to start to get into the data. Should we, maybe we share the results from the polls real quick?
sure.
Um, so let's see. All right, so I'm going to share the results. So when an HCP recommends medical cannabis, I mean it's split pretty evenly, 60% saying that's true, it results in lower exposure to THC, and 40% hypothesize that that's false. When an HCP recommends medical cannabis, it results in higher exposure to CBD. 60% said it's true, and 40% said that, nah, I don't think that that's gonna happen, that's false. And I see the logic in both. And I definitely think both can be true. But where is the trend pointing towards? Well, we'll take we'll take a look and we will see. But it is almost a near 60-40 split on those questions. So moving into table two, this is reported ailments, self-reported conditions being treated with medical cannabis. Fairly straightforward. I know there's a lot of stuff here, but the most common ailments, which I think we should expect, if you're familiar with the literature or work with patients, anxiety, chronic pain, sleep issues like insomnia, as well as mood, such as depression.
You just look at the provider recommendation status, the first two columns, go down to depression. It, it's pretty different. I think if I I conclude that if I'm depressed, my doctor is less likely to recommend cannabis to me. And if I go down to migraines, I see the opposite. My provider is more likely to recommend it to me. Not that it's earth-shattering, but it's just curious to see these trends.
Absolutely. And I think there's a high use for mental health or psychiatric symptoms in this population. So I think that there's opportunity for a risk benefit conversation there. So just, and again, for everyone participating, happy to go back to any of these slides. So slide 3 is the route of administration where respondents, were surveyed on how they use cannabis. And lo and behold, they found that smoking is by far the most popular method. It always reminds me of what one of my early mentors said to me when I worked in diabetes and endocrine research. And he said if patients could smoke their insulin, they would probably adhere to the regimen. And
This surprised me that smoking was so physician recommended, so doctor recommended.
I don't know if it's the way it's asked, but it's also, there's a lot that said no as well. Um,
Yeah,
and I don't know if it's that they didn't object to it, and maybe smoking was lumped in with inhalation. Um, but again, it's
yeah.
Right, but I think that that's something, not to interject here, but I think that that's something that Len might be able to actually give us a little bit of insight, either now or later, about like when he does talk to the patients, just anecdotal, do they say that more of them are smoking, I guess, because they can control sort of that experience more than like manage their symptoms more than with an edible. At least that's my perception. I don't really know that, so
and
just curious.
That's a great question, Teresa. And another thing I'll throw out there is we did get a question from the audience about breaking down between flower vaping and using the cartridges, which is an interesting distinction as well. So those kind of processed oils that attach to a battery, they're like a little tube or cartridge, versus using a whole flower vaping. I don't think they had that level of resolution.
Len?
My thinking, and I don't have statistics, but I think there is an overlap. I think people see vaping as smoking, and I don't think they differentiate that much. I do have I, somewhat of a predictable older class of patients who were introduced to marijuana probably in the 70s and 80s who were smoking, joints or rolling it into cigarettes or making it into pipes. So I think there's an overlap. I don't know how accurate this data is.
Right, the resolution on the data might get a little fuzzy around the edges.
Right. And
Beverages
I think that
also
the
surprised
question,
me.
I'm sorry to
Go.
interject, Jahan, but I think that it depends, I have to dig a little deeper, but if they were allowed to tick all that apply, in which case, like to Len's point, smoking and vaping, they're going to double count that potentially, there could be overlap. And they're taking edibles, so, were they only allowed to choose one? So much of this has to depend on how many responses they were allowed to ask, or was it asked what their primary method was, or could they tick all that apply? Just something to put out there that makes these numbers look a little interesting. So,
I believe they're allowed to choose more than one route of administration. We can take a look. I have the survey open in another tab. One thing that's hard to believe is the low rate of beverage consumption because of the sheer availability of hemp beverages in every store. So maybe they're not counting those as cannabis products. Or maybe this data is from before the hemp beverages have really hit the shelves.
Yeah.
And table 4 is a side effect by route of method. It's a chi-square analysis, which Teresa could tell us all about if she'd like to. Um, but basically, this was looking at side effects across use methods and groups. And basically, they saw no significant difference in rates across either groups, whether your provider was recommending it, whether they were aware. There was no significant difference. And the most common effects were dry mouth and increased appetite. So I guess I would say that this, I'll punt it to the group. Uh, there's equal side effect rate suggests that guidance doesn't necessarily impact the type of adverse events or mitigate adverse events that people have, such as, again, dry mouth, increased appetite. And might this, and Teresa, I think a question for you. You've done a lot of patient surveys and clinical work. Patients are recalling their adverse effects. So how much of that could play into it that maybe the only thing they remember is having dry mouth and increased appetite?
so yeah, so there's also this sense of this internal validity that I always like to, and they're not getting anything wild, right? So you expect that this is a known sort of effect of cannabis products, dry mouth, increased appetite, whether they fall into that or whether, so it's also that internal validity. And, I'm surprised we didn't get the increased heart rate. We do get a little bit, of the paranoia, but not much, right? So I think that for me, it's what you would expect, really.
Fair enough.
I mean, I don't know if Len has any comments on that, but I was not wowed by this. It's like, okay.
There are so many medications that uh, there are so many medications that cause dry mouth, and
Right, that
it's
too.
possible to separate them out. Um, It's interesting. It doesn't seem to show any pattern of the cannabinoid hyperemesis because everybody's appetite is increased, not decreased, and that kind of skews the skinny hippie persona that we used to see. But everybody's appetite seemed to increase in this group.
Excellent. And we had one comment from attendees that it is good to see that anxiety is not, in the rise with the reported groups. Like it's not very common. It is interesting that it is reported for beverages, though, but we don't see it, reported much as a side effect elsewhere.
Right, and is that because we don't know what the ingredients are? Is there caffeine in there or something in the
Yeah,
beverage, right? So we don't know. I mean, this is
agree.
The main point is that regardless of whether my doctor recommended it or didn't recommend it, the side effects are the same.
Yeah, I
That's
like
the main
that.
point.
All right. Moving on to table 5, looking at the frequency of use, grouped use frequency by clinician and physician involvement. So we have provider recommendation status, yes or no. We have PCP awareness status, yes or no. And basically, the key finding here, and I'll leave it up for a minute, is daily or multiple daily use significantly more common in the provided, guided, or PCP aware groups. Um, why might that be? Is more frequent use reflecting maybe better self-management, or maybe they have more severe conditions and they're following a treatment plan? Is higher frequency better, or are they just more aware of it? What do you think?
Well, if my doctor is recommending it to me, I'm using it more frequently. Period. That's all it says. And it's not a surprise.
Right. And we
I
have,
think it's,
go ahead.
yeah,
Yeah, I don't think this is a surprise. Western medicine is about prescribing medications on a daily basis, and if you're going to prescribe it, it's usually again for a chronic illness, a chronic condition, it's going to be more frequent. It's
That
just logical.
makes a lot of sense. Um, and we had a participant asked, were suppositories an administration option? Absolutely. The administration forms were self-reported, so they might have gone in the other category um, with some of the other lesser known administration forms or lesser appreciated. So going into table 6, provider recommendation, the outcomes, right? So these are the mean or average scores and ranks of various health and usage metrics. Sort of the significant findings, that is statistically significant, mathematically significant. We don't know if they're clinically significant. So let's start with the math. Um, were greater perceived mental and physical health impacts, higher CBD dosing. Again, we're talking 17 milligrams versus 4, more likely to seek dispensary advice, and also higher social support. So here are a couple, like two or three thoughts here. CBD dose increases. Does that suggest the clinician is prioritizing that? Um, Greater social acceptance, right? Higher social support. Does that mean that maybe they get less stigma because they're using it within a medical framework? And or is it maybe survey respondents maybe didn't have a clear understanding of what a cannabis clinician is and may not know if they met with one?
yeah, these tables are tough. If you individually would like to spend more time on them, my recommendation is look at the last column. The p-values are impressively significant, and just look to the left and see what metric they were associated with. People who, for example, people whose doctor recommended it spent more money on it. No surprise.
Yeah. And they spent more money, seemed to acquire products with more CBD, and seemed to see that there was more social perception or support. And that might be that, you know, maybe the thing is, oh, doctor recommended I use a different product with CBD. Here's why, and they're having these more productive discussions with their family members, loved ones, and support circle.
Yeah,
So,
and the last one, perceived efficacy on the last line is an important one to gaze at.
yeah, 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 perceived efficacy on the bottom. Sorry, I jumped ahead there. And now I'm going to jump ahead again. So, table 7, PCP awareness outcome. So, this is similar in structure to table 6. And the statistically significant findings, there's many, but these are better reported physical and mental health outcomes, greater perceived efficacy, higher monthly spending, more frequent use. So what's interesting here is, I'll kick this to the doctors, right? Even without verification of formal cannabis training, physician awareness improves outcome. Do you think that is likely, even without having formal cannabis training? Does that influence the results?
From my perspective, I think this is in comparison to the bud tender awareness or the bud tender training that you're comparing, somebody who's looking at the overall health and benefit to the individual from two different perspectives. Um, I think that it's if it's not the a clinician asking these questions and providing some guidance, then it's somebody completely with a different agenda and pushing this medication or this treatment. It could be the sale of the product; they get incentivized to sell more. It could be that they're more recreationally oriented. So I don't I don't think it's a brainer. I do think that medication of this sort, if it's going to be used as a medicine, should have guidance from a clinician who has a person's whole health interest in the mind. So not a surprise.
Yeah, absolutely. And I think even just that exchange where maybe, in this day and age, there's a book I read called The Patient Will See You Now. And patients come with information to discuss with the clinician. And even if the doctor is not informed about a particular treatment option or medication or where they're using it, maybe just having that discussion with someone who has, a broader scope of medical background might have benefits as well. I definitely would agree with that, Len. And oh, and we have a comment from a participant. I love it. I love this comment. It could be placebo, assuming it works better because a doctor was aware. I love that idea. And I think there might be something to that. I would be willing to say that maybe there is a percent of the effect that could be attributed to just feeling more confident and less anxious about the use because you've had a concern addressed by a clinician, right? Oh, I'm taking these blood pressure medications. Is this gonna, have an effect? And you have this discussion, maybe it helps you feel better. Um,
We have another comment, Jahan. Do you want to read it
yeah,
from?
so let's see. Is the advice seeking frequency the communication between the doctor and the patient? Um, yes, I believe that is um, what they are referring to is whether the frequency of seeking advice about
Exactly. That's exactly right.
in those different groups.
Right. So
So,
how often they spoke to them about it.
I think
So we have 20 minutes left. How are we doing on time?
we're doing great. We have two more figures. So even without a cannabis background, PCPs should probably routinely ask about cannabis use in this day and age, or cannabinoid use might be more appropriate. Um, And if the doctor is not educated, yeah, they did consider that there is a lot of information about whether the clinician, there's a perception there. They didn't verify whether the doctor had a certificate or is part of a society that offers education. So we don't know the clinician's education level responding to this, which would be great to know. All right, so moving on to the data that they feel supports their hypothesis. Cue the amazing music right now. All right, the big reveal. So this is a figure, a humble figure that reports the overall efficacy between those who worked with a cannabis clinician, and we'll just call that a clinician who, was aware of their use or providing some guidance about their use, and those who did not. And Teresa, if you want to talk about statistics, you know that there's the Mann-Whitney U-tests that are used here.
There
But
are two figures. This one says cannabis recommended, and the following one is my doctor was aware. So there's only two figures. This one is my doctor recommended it to me, and the next one is my doctor was
Yeah, the
aware.
knowledge, right? PCP
Yeah.
knowledge. Yeah.
And so this, I believe this reinforces the benefit of professional guidance. So even disclosure to a primary care physician without specialized training improved perceived efficacy.
Could be placebo. We um,
So,
we don't know that, but
right.
who cares?
I mean, if you're having, I mean, if the placebo is just tricking the body to do the work, I mean, we're having a good effect here, a good
Yeah.
outcome. Everyone
Right, right.
has
And
to win.
sometimes they do an analysis where you take that away and you still see an effect. In this
Yes.
case, it looks like that might still be the case, right? They still
Yeah.
might see something if you took away the effect. So it's
And so
adjusting
Yeah.
for that placebo potential.
And so this again, just to remember, this is patients reporting higher relief, higher perceived efficacy. Now, what did the clinicians see?
That wasn't measured in this study.
So,
Study.
right.
Yeah.
So this is a reported overall efficacy between those that had informed their primary care physicians and those who had not. So patients whose PCP was aware of their use also reported higher symptom relief.
Mhm.
So, again, I'll just to go back and forth between those slides. These are if the clinician recommended it, what was the patient's perceived efficacy? Oh, the doctor recommended it, it worked. And then if the PCP just had knowledge about it, perhaps it's disclosed, perhaps there was discussions about use, that also seemed to increase the perceived efficacy as well to a statistical significant level. No small feat. All right, and so just in the interest of time, we want to summarize the main findings and talk about some of the strengths and weaknesses. So, um, some of the main findings here are that 55% reported clinician medical cannabis recommendations, 67% reported that they were aware, 33 again opted for non-disclosure. Most common ailments, anxiety, chronic pain, insomnia, and depression. Most common routes of administration, smoking, edibles, and vaping. And we discussed kind of the limitations of reporting those, and people might confuse smoking and vaping as kind of one category. So regarding those working with a cannabis clinician reported better efficacy, better physical and mental. The findings reported that those working with a cannabis clinician versus those not working with a cannabis clinician, that is a clinician who's aware of the cannabis use or recommending cannabis use, there were similar THC dose intakes. So THC dosing did not appear to increase. I think I got that right, Phil, right? And
Yes, contrary to the hypothesis.
but they did observe higher CBD dose intake and
Right.
more frequent, more expensive use, as well as different routes of administration patterns. Now, the frequent and more expensive use pattern, this has actually been shown elsewhere that the first couple months that someone becomes a medical cannabis patient is the most expensive part of their journey because they're trying different products, they're tracking their symptoms and effects, and so they might try many different things to find what works for them or what combination of products work. And this is a great quote from the authors. Undertaking cannabinoid therapy with PCP awareness or guidance from a cannabis clinician is associated with better outcomes. And this could also be an argument for why some operators may want to maintain their medical cannabis status as a dispensary.
Yeah, so Jayhan, do we have a minute to look, or did you have, I was going to make a reply to the chat around the HCP. So do we know if the question, you don't have to pull it up, but can you look to see when they say healthcare provider or cannabis specialist, do they have like nurses or whoever might be certified, or how that question was asked?
So it's a
Doesn't have
primary
to necessarily
care
be a
physician.
physician, right?
No, no,
Or,
it is a primary care physician.
okay,
Yeah,
okay, thank you, okay,
that's who they wanted them to talk to was their.
okay. So it was a physician, perfect. But and we know that there are many other healthcare practitioners that have like certifications in helping patients uh, around their cannabis use.
That is
That's
a good point because they could have talked to other people in the office as well about this, right?
potentially, yep.
And so some of the strengths and weaknesses. Um, so some of the strengths, right? This is pretty decent number of respondents. I think it's well executed. They had some comprehensive data collection. It's one, it's hard to recruit people in the study, and two, to get them to fill out a very long and lengthy survey can also be a challenge. Um, there were some potential weaknesses, right? This is observational, self-reported. Some questions were about illegal activities, which not everyone likes to document and publish their illegal activities. Um, and they didn't include non-cannabinoid treatments, and there was also kind of a vague definition, as you perhaps have smelled while we were working through this paper, of what a cannabis clinician is. And there really wasn't a control group per se to compare. And great, great, great. So moving on, just loving the comments coming in. So just some questions for us to ponder in our remaining time together. Um, how can healthcare providers better engage patients regarding their cannabis use? What steps should be taken to improve the comfort and knowledge to this end? And are there ethical considerations in recommending cannabis products to your patients? I think the last one is an age-old question, regarding what the laws, regulations, policies, and practices are in your state. If there are issues with using the products where you say rent your apartment, that could lead to complications, maybe with your job. So there might be things you might want to check in with your patient about, or even your friends. Hey, you're a truck driver. You might want to check with your employer about whether or not you can even use these products. Will that create a complication down the line? So, thinking just from those practical experiences. Um, well, we can come back to those questions, but just some things to think about.
Can I add here that ethical considerations certainly will depend on the state that either allows the use of cannabis or not, and in what forms. I think there are concerns that if you engage in discussions with the patient as to cannabis use, and they use it capriciously and have problems with it, then, and you've notated that you've documented your discussions with these patients, it could construe this as a legal problem. If there's an accident or some other lawsuit that could reflect back on the clinician, it could reflect more kindly if they are documenting guidance and appropriate steps to be taken and parameters. But in states where there is recreational use and it's not monitored very well, it could be a liability of the physician in discussing this or keeping that open in their chart. I don't know if that's happened, but it's possible.
I, I think it is a very definite possibility, and I'm sure things that would fall under that category, subsets of that have happened. And I think even especially in the early days of like medical cannabis laws, um, in different states for sure. And I think as things evolve and different products are more widely available, we will see this happen more often. So this is an active area of research. There are a lot of studies out here. Here are two more that you could screenshot and look up. Again, charting the therapeutic landscape, a comprehensive evidence map on medical cannabis for health outcomes, and also looking at cannabidiol-related attitudes and practice behaviors among physicians in states with and without marijuana legalization. And so, again, this is an active area of research, um, and these are just two papers that we pulled out to say there's a lot going on here. Some questions to further ponder. Do you believe the study conclusions, recommendations, or knowledge results that these result in better patient outcomes? Will this study influence you as a provider, or perhaps influence you to talk to your provider? And what further studies could be done? Those are things I think we've addressed pretty well today. Um, and just in the interest of time, I'm going to move through a couple other things. I think this paper absolutely addressed a unique question that's not commonly asked in cannabis research. And again, I think many outcomes, efficacy and side effects may be influenced by engagement with healthcare providers. And here's another quote from the paper as we reach the end of the road. Healthcare providers should consider being open-minded about addressing cannabis use, medical and general adult use with their patients, especially as different products are being available. We'll have our next journal club June 3rd, where we will discuss amyotrophic lateral sclerosis or Lou Gehrig's disease, a paper published by some colleagues, including Greg Carter and Ethan Russo, big time researchers in this area. July, we're all taking a break. Please go to a barbecue or whatever you like to do in July, and we'll be back August 5th with a very interesting chronic pain review. Dr. Molloy, can you talk about this pain review? I thought it was fascinating when you
Yeah,
mentioned.
it's not a Cochrane analysis, but it's like that, and it's suggested guidelines for clinicians put out by the American College of Physicians, the ACP, published in the Annals of Internal Medicine about a month or two ago.
And I think Dr. Kamen, who is a pain specialist and on a number of boards and could probably contribute a lot to that session. That's going to be a very interesting one.
Excellent. Well,
I, can I make one last comment, Jehan? Your last slide said maybe healthcare provider engagement, listening, and being supportive leads to better outcomes. That's been shown in many other diseases already. It's been shown in rheumatoid arthritis as a rheumatologist, it's been shown in gout, it's been shown in lupus. That empathy is and an open ear is probably our best medicine.
so you're telling me many treatments just involve a good conversation. I,
There's some good research on that. Yeah, exactly.
I would agree. I would agree. I
Yeah.
definitely, and I think so much of it is helping people understand, um, least from talking with medical cannabis patients and what they share, is so many of them just want to have a conversation and share the benefits and risks that they perceive about these products. And is this normal? And is this unique? And why might it be working for me? And why might these other medications not work? Or, and they have questions like that. And so I would absolutely agree that I think having any, you know, share something somewhat, I went to a, somewhat personally, I went to a dermatologist, had this spot, and I was like, oh my gosh, what's this spot on my skin? And I'm all like concerned about it. And he's like, oh, it's nothing. He's like, yeah, don't worry about it. If you want it removed, I guess we could, but it's
Well,
like, well,
yeah. Well, that's reminds me. I mean, a lesson I learned as a clinician seeing patients is to meet the patients on their field. They don't have to meet me on my field. I meet them on their field, what they're anxious about, what they want.
right. Yeah. I think it helps a lot sometimes just having um, someone who's a lot of experience, deals with
Right.
complex scenarios, being able to talk
Mhm.
you through it can sometimes change your perspective too, and how you approach a condition or a challenge, or your perceptions about them. I think
Yeah.
that's probably, I would agree that if a clinician can help change your perspective and approach to something, I think absolutely that can influence your outcomes. All right. Um,
Okay.
so there we go. I would say you can go to prctrialsplus.com. You can sign up for the free version of the membership. The modules, of course, you have to pay for, but we have a lot of other fun things on the website. Please check it out. And we look forward to seeing you at one of our future meetings.
Thanks,